We are reaching to the last speaker in this session, Professor Jouclyn Prof from UK. He will speak about the ongoing challenge of pelvic congestion syndrome.
Thanks, everybody. As we go on, it's nearly tomorrow. I'm talking about pelvic congestion syndrome. It might be that we've covered a lot of this stuff. Let's hope so, and then we can get on with dinner. Chronic venous insufficiency. We know it's very common. We know it actually seems to be an autosomal dominant genetic, probably connective tissue disorder. We can discuss that. And we know that if you've got a genetic tissue disorder, surely it's going to be everywhere. So this is going back. I know that everybody here is quite good on pelvic congestion syndrome. Usually you go to these conferences and people deny that such a thing exists. So forgive me if I'm coming at it from a sort of child's point of view. We know that it's not an X-linked thing, so it's not a genetic thing. So why do women get troubled by venous insufficiency more than men? Because they have a hormonal, vasoactive hormonal cycle, and they also tend to get pregnant more than men. And when they do, it's a huge pressure on the venous system. So if you have a weakness of the venous system, it will manifest after pregnancy. And we've discussed May-Thurner and Nutcracker syndrome. I'm not going to go into that just now. So if we establish that it's a weakness of the venous system with the valves not working, it's a gravitational thing, and you can guess what it's going to do to you if you stand up. Everything below the heart is at threat, but not every territory at the same time. Depends which particular venous territory is refluxing. We all accept that men get pelvic congestion of their left testicle, called a varicocele. Well, women do as well. It's just tucked inside. It is exactly the same problem. Only women get it more than men. And men also then will get disturbance of the menstrual cycle with menorrhagia, as we heard that amazing case about attending to the venous constriction. It's like having a tourniquet on the uterus. Surprisingly, it bleeds more. And dyspareunia, if you've got a tourniquet on the venous outflow of the vagina. And vulval varices obviously must come from above. They can't come out of the legs. And so on and so forth. Hemorrhoids, varicose veins of your backside. And men get it too, but it's a bit harder to spot in men because they don't have the cyclical arrangement with menstruation. So that we've got these specific subsets. We all know about legs and ulcers, more of that tomorrow, but pelvic incompetence, all the stuff in the abdomen and pelvis can be affected as well. And if you decide not to address it, it'll go on, and we'll call it chronic pelvic pain. So there is a bewildering, a galaxy, if you will, of presenting features, all of which are to do with pelvic venous reflux, as we've been discussing today. And it seems like a bewildering array of presentation, but it's all exactly the same once you accept that venous insufficiency can affect any venous territory, and it's incredibly common. So when you have things like chronic pelvic pain, why not consider those large veins that you saw on the CT scan or the ultrasound and think, well, maybe that's our pathology, because that is one of the most common pathologies. And you also have to accept that not everybody feels venous hypertensive stretch. So not everybody finds that painful. So then, accepting those two things, all of this becomes a bit more obvious. We've already seen this list. The patient tells you the answer. The answer is in the history, because if they have anything of this list, dyspareunia, hemorrhoids, pains in vein problems in pregnancy, they've got pelvic vein reflux. So in terms of diagnosing it, take a good history, the patient will tell you you will be 95% sure, and a duplex scan on the top will confirm that. And a transvaginal duplex, as we've heard, is probably the best of all, but the least available. And it's all about, duplex is all about the operator. So for other people, it'll be venography. And if you suspect pelvic vein reflux, you're probably going to have to go to venography anyway. But this is what you see on a duplex scan. I'm lucky enough to have a very good duplex service, and, well, that's coming from above, isn't it? Oh, look, is that a varicocele? Oh, no, it's a woman. There it is again on a CT scan, and this is obviously very uncomfortable, these periuterine varices and vulval varices. None of it is a surprise. Here is a CT scan just presented in a volume rendering, again showing the pelvic source of the inner thigh recurrent varices. So we did our own little audit of our practice and found that if you suspect, after history, if you suspect it's pelvic and the duplex scan says it's pelvic, when you do a venogram, funnily enough, it's pelvic. So that's a little bit sort of a circular argument, but we found a 95% agreement between the history and duplex saying it was, it validated the duplex scan for pelvic reflux. So we do a pelvic venogram. We do it the same way that you do it. We come from above. Increasingly, I'm starting to come from the antecubital vein, just to try something different. But normally, I've come from the internal jugular. And you've got to do it with Valsalva maneuver, and therefore under local anesthetic, or else you're wasting your time. So here we are in the lab, and when you get pictures like this going down to the vulva, it's fairly obvious that, you know, that is the cause of the pain and the vulval varices, the periuterine varices. Lateral is a terribly important thing. Do the venography in lateral, and you can see the sort of sponge here going underneath the uterus and down into the vagina, in certainly with menorrhagia and dyspareunia. And I'm more likely to use foam sclerosant for that rather than just coils. The angiogenic mat following strip varicose vein surgery is beautifully demonstrated here, and the reason why strip surgery has been superseded by thermal ablation with its different pathology of healing without angiogenesis. Men get it too, and it hurts, and it's associated with all sorts of sexual disturbance because of the pain, painful engorgement after erection, but it can be treated the same. Hemorrhoids and low back pain. It isn't low back pain, it's actually, well, it's sacral pain that women get, and you can see here the refluxing pathways that cause that pain. And continue down in the hemorrhoidal veins, and we can treat now external venous hemorrhoids from in a much more clean way without having to take your pants off. Because in the same way you can inject hemorrhoids with sclerosant, well, you can put it in a catheter from above. So a couple of films which we labored to make work earlier on. There's an angiogenic mat refluxing down, refluxing recurrent varicose veins. And then pelvic congestion. Here we are on the left, valsalvaing down. You can see very quickly, you've got to do the Valsalva. Whoa, look at that. How uncomfortable does that look? And you can coil it and eliminate the reflux. And so the film carries on. Let's go to the next one. Which veins are involved? Mostly it's the left gonadal vein, either ovarian or testicular, but the deep veins are 50-50 left and right also. The least affected tends to be the right gonadal or ovarian vein, all for presumably anatomical reasons. biggest meta-analysis was published by John Moss in 2016. They looked at nearly 3,000 papers on the subject, finding barely 22 that they thought were worthy of actually looking at, and only one low-quality randomized controlled trial. I'm going to need help here. Incredibly variable technique. Very few complications, although coil migration is real, it's rare and should be avoided. Thank you. Okay. I'm last man in, I should be all right. So coil migration, rare but real. I now use detachable coils to avoid that. So of this rather poor quality data on the subject, there's a high level of at least short-term symptomatic improvement, which at least means we're pointing in the right direction. We are attending to the pathology at play, which is the chronic venous insufficiency in the abdomen and pelvis. No concerns about future fertility. And there was just some transient pain, particularly following sclerosant use. So this is the last slide of the day. Despite the heterogeneity of diagnosis and treatment and rather poor understanding of the pathology, pelvic vein embolization seems to provide symptomatic relief of chronic pelvic pain in the majority of women it's used on, and seems to be quite safe. The quality of evidence is admittedly low and more work needs to be done. We're getting short-term symptomatic relief of approaching 90%. There's very good correlation between your history and the presence of pelvic vein reflux. And where the chief problem is varicose veins of the legs, but with a pelvic source, you must address the pelvic vein leak before you try to tidy up the legs, or you'll get continuation of symptoms and recurrence. Pelvic vein embolization appears to have a role in the treatment of hemorrhoids. It seems to have a role in the treatment of dysfunctional uterine bleeding, as we've heard very directly today, and whatever the last line said. But I was looking away when it switched off. We need to do more work, and it's particularly, yes, it's very important in treating Klippel-Trenaunay syndrome, which I know is something which bothers everybody here. So I think with that, I will step down. I'll see you tomorrow, but I'll see you to Professor Radwan.